So, I am really happy today to be able to share with you an interview with one of my favorite researchers. Dr. David Campbell is here from the University of Calgary to talk to us about one of the programs that I think will be relatable to all of you who have been pitching today and all of you who have been watching. So, David, welcome. It's so great to have you here.
Thanks, Krista. It's great to be here with you.
So let's talk a little bit about the work that you do. You do a lot of work around type 2 diabetes and homelessness. And I wondered, one, what was it that inspired you to get involved with that?
Yeah, so starting there. So my interest in kind of the intersection of healthcare and chronic disease and homelessness dates back to early days. I was back to the beginning of medical school, really. When I started medical school, there was a group here at the University of Calgary who had been working on trying to get a student-run clinic set up. And I know there's clinics like this at many of the medical schools around the country, but Calgary didn't have one until I was a first-year medical student. And so I was part of the first class to launch the student-run clinic at the University of Calgary. And so we worked in conjunction with the Calgary Drop-In Center, which is actually the largest homeless shelter in Canada at that time. And we established a clinical program there, working under the direction of the family physician who worked there. And every week we got to provide, some degree of patchwork primary care for patients that were experiencing homelessness. And through that experience, I learned a lot of things. But one of the things that really struck me was just how complex it is to manage a chronic illness like diabetes when you're facing such circumstances and when you're without a home and don't have all the luxuries that many of us enjoy. Diabetes management and self-management, which is already a complicated endeavor, becomes so much more difficult. And I remember seeing people with conditions like diabetes or hypertension at the homeless who, for whatever reason, couldn't get the care they needed, couldn't look after themselves the way they were told to. And so they would come in with late stage complications of their diabetes all the time. And so that was many years ago. And from there, I went on to do my research and clinical training. And it was during my endocrinology fellowship that then, it kind of came full circle. And I remember being an endocrine fellow on the wards and, even as an internal medicine resident, seeing people coming in DKA. But a lot of times there are people that were without a home or without a stable home and sending them home back to the streets, back to the shelters to try to manage their diabetes. And you'd see them back through later with DKA again if they're type 1s, or people coming with for amputations and heart attacks. And, and it seemed like a recurring theme throughout all of my training. And so towards the end of my training, I decided, what, I want to study this a little bit better more. And I think there's probably ways that we could structure our healthcare system to provide care better for this underserved population.
Yeah, and you've really focused a lot on these structural changes. And I know that your latest project is one that I think the audience today is going to be very interested in. So, do you want to tell us a little bit about what that is and the change that you're trying to make?
Yeah, absolutely, Krista. So, as you know, Krista, that part of my work is really engaging with people with lived experience and trying to give them voice and trying to study issues that matter to them. And I've done that over the last 4 or so years by using community-based participatory research. So, really engaging with people in the community who have the lived experience to tell me and my team what's important for them and what their priorities are. And there have been a number of things that have come up over the years. Healthy food access is one that's constantly coming up. But there's another big theme that always comes up when I talk to folks in this community and people with this lived experience. And that's people who say the healthcare system is just not arranged in a way that helps me to get care. When I'm looking for a home, meeting with housing workers, struggling some mental health or problems, and then I go see a doctor and they say, okay, great, you've got diabetes and now you need all these other appointments. And yeah, you need to go see somebody to get your eyes checked. And yeah, you need your feet looked at, but we don't have that service here. So you're going to have to go over there to that other hospital and get that done. Oh, and then you need to go to the lab and get your kidneys or your A1C done. People just have said it's just a huge burden and it's tremendously difficult for them to do all those things that we ask them to do with home. And so what really came up through a lot of the work is that people were asking for kind of a one-stop shop, one place where they could get all those things done. And that's what we're really to do next. We've in conjunction with the Drop-In Center and the Mustard Seed, so two of our local shelters or wellness centers here in the inner city of Calgary, to provide this one-stop shop. And we call it the SAFER program. And SAFER stands for Screening for A1C, Feet, Eyes, and Renal Disease. And so people can have all of those various screening maneuvers that we ask people to do in one visit. And so they come and see me, not me, my team, my my nurse and research associate that work down the shelter, like right in a place where they're familiar, right? And that's another big thing, is that people have told me they don't feel comfortable going to hospitals a lot of times. They face discrimination and they've had bad experiences in hospitals and they don't like going to hospitals. And so an important facet is bringing care to the population. And so that's what we do, is we go right to the shelter, and there we do everything. So a point of care analyzer that does our A1C and albumin to creatinine ratio, so we can get their A1C and kidney test done right on the spot. We've worked in conjunction with our local ophthalmologists and a tele-ophthalmology program. So we have a panoptic retinal camera that will take photographs of the retinal fundus and are then sent to our ophthalmologist in Edmonton to do the full eye screening. And the nurse that works with me is trained in foot care as well. And so she does the full foot examination and provides basic foot care right on the spot. And then we've also, so that's a big part of it, is the screening, so that we detect the problem, and then we've also built in dedicated referral pathways, because that's, getting back to what people tell me, another huge barrier is the wait times. People say, yeah, somebody tells me they want me to see a kidney doctor, but the wait time to go see the kidney doctor is for 6 months. And by that time, I don't know where I'm gonna be living. I could be in Vancouver, I could be in another city, I could be in a different part of the city. And so keeping track of appointments that are so far down is really hard when people are in such a state of flux. And so we actually worked with our local colleagues to develop these referral pathways where we get people into care within 2 weeks. And so if somebody needs to be seen by a retinal specialist or a kidney specialist or a foot care provider, we have those built in to have the referral made and the patient seen within 2 weeks. So that's kind of the gist of the program that we've been working on over the last year, Krista.
It sounds so amazing and so very, very helpful for people who are dealing with housing insecurity. And again, like you said, they may not have the ability to be in a place 6 months later, let alone keep an appointment for something at that time frame. So this makes me think a little bit about the previous project that you did, Home Sweet Homeless. A lot of the feedback that you got from participants was around food. So is there any discussion about food in this particular project, or is that something that's separate?
Yeah, good question. In my mind, we need to address all the different barriers that people face, and they each need their own solution. Unfortunately, there isn't a panacea, kind of a single solution that's going to address all the issues. So no, that's a different, food insecurity and food access are issues that aren't going to be addressed by the SAFER program, but they are issues that are still top of mind for me because they were brought forth by the community. So they're issues that we continue to work on here. We've got a few other programs that are in place to work on that, and we've got programs to address food insecurity in people living in community, and then we're also looking at a program in culinary medicine to teach people in transitional housing, as they're leaving emergency shelters where they've been provided their food continuously for years sometimes, and may have forgotten or never learned to prepare healthy meals. And so we're working now to develop a program where we train them and teach them about healthy meal preparation and try to give them the knowledge and skills that they need as they go back into a more stable housing situation. So yeah, different problem needs a different solution, but I think there's no shortage of problems to be addressed in this population.
Yes, and you're doing some amazing work in bringing to light. And one of the reasons that I asked the question is because you are someone who works very directly with the community. You are not coming in with your ideas about what solutions might work for them, but actually working very directly with them and asking them what it is that they need in their lives. And why has that been important?
Yeah, so a really good question, Chris. I think that, any of us that is familiar with the literature know that there's a long history of interventions to address diabetes care or diabetes outcomes in a variety of populations that have tried and tested, and people think they've got a great idea. This is how we're going to fix the diabetes problem in this population. And when they go to implement it, it doesn't have the desired effect. It doesn't actually do the thing that they thought it was going to do, either improve people's self-management or lower their A1C or reduce the complications. And there's literally thousands of papers, literature about failed diabetes interventions. And to me, I think that there's probably a number of reasons for this, but the biggest one is that sometimes we develop programs or initiatives, ideas kind of with our own knowledge and wisdom. As healthcare providers or as researchers, we think we know what the problem is. But if we develop solutions to problems that we think are there, but they're not the real problems underlying people's behaviors and people's outcomes, then it's not surprising that we don't have the results that we want to have. And, Chris, I think that one of the most powerful examples of that is from my own community-based work. So prior to the Home Sweet Homeless project, the clients with diabetes advocacy committee that we had, I went into that with a very strong preconceived notion that the reason I was seeing all these patients in DKA with diabetes complications was education, that there just wasn't good diabetes education. We needed more endocrinologists and more diabetes educators, and that would fix the problem. And when I went to the community, I kind of had this idea that's what they're going to tell me. That's, if I had to make a hypothesis, that's what I would have thought was going to come out. That was so far from the truth. When we did that concept mapping exercise, that was actually the lowest ranked item for people to experience. That was the lowest priority. The things like accessing to healthy food, accessing the healthcare and the screening maneuvers, the emotional wellness and their psychosocial comorbidities, those things were so much more important than education. It just goes to show that if I had tried to develop a program 3 years ago, I would diabetes education program for inner city populations. And I can bet that probably wouldn't have been successful based on what I know now, that that's not people's real problem. People don't think that more education will help them. They need the resources and the programs that will actually make it easier for them. So just an example of how I think it's so critical that when we develop new initiatives and interventions, it's done in conjunction with those who we're trying to serve rather than kind of on our own accord.
Absolutely. That is something that I think a lot of us need to consider when we're planning out the programs that we're looking at. Is this what the community actually needs? And is it what they will actually use? And in keeping with that, I wanted to ask you another question, which is there are often a lot of misconceptions about people that have housing insecurity or experience a lack of housing. In terms of what it is that we think they need, what would you say to people who are considering this type of work in terms of the misconceptions that we have?
Yeah, great question, Kristen. Actually, that's really leads well into what I was hoping to talk about, which is we have a new clients with diabetes action committee here in Calgary, different from the one that we had in Toronto a few years ago, but same principle, same idea. But what's really been interesting working with them is, they're different people with different experience and in a different setting and context. And so because the context is so important to people's lives and the experiences that people have, their priorities are actually different too. And so when we did a priority setting exercise with this group that we have now here in Calgary, which is actually just a mix of people with type 1 and type 2. So we've got a number of people with type 50-50. What was really interesting is their top priority, certainly food access and, healthcare access were high up there, but their top priority was actually around stigma and this idea of misperception, discrimination, judgment that they face kind of at all places. And we know that there's stigma that's associated with diabetes alone. Live with diabetes face stigma all the time. People that have to check their blood sugars and have to do so in secret and go do it in the bathroom because they're ashamed or feel stigmatized because of need to self-monitor, use insulin, same thing. There's lots of stigma around diabetes, but there's a special kind of intersection between that diabetes stigma and the stigma that people face when they're experiencing homelessness. And we've heard lots and lots of stories of people, tragic stories of people having a hypoglycemic event in a shelter. But rather than getting the help that they need, they got kicked out or barred from the shelter because somebody thought that they had been using drugs or they had been intoxicated. And that's just one example of many, that there's this intersection of stigmatizing experiences for people that are facing diabetes and homelessness. And so that's what this group is currently working on, our current group. And what we're hoping to do is develop some kind of educational or training module that will inform providers, maybe healthcare providers, but especially the social care providers that work in shelters, that work front lines, maybe it's law enforcement, maybe it's EMS, to really inform them about what the realities are of living with diabetes and maybe try to challenge their preconceived notions of why somebody might be behaving the way they are and make them think twice. So it's a huge problem, and our group here has really prioritized that as the issue that they've seen the most need for action in. So again, not what I would have picked in terms of an intervention, but that's what they felt the greatest need was. So we're empowering them to succeed in addressing that issue.
That's so fantastic because, again, not what I would have thought of either, but we need to ask people what will be important to them if we're going to do these types of interventions. And so, my last question for you, because time has flown by, as it always does when we're talking about this topic, is really what is the response that you're getting to your new programs from the people who are using them? How are they responding?
Yeah, great question, Krista. So, we're at this stage right now of, so for this, the SAFER program or the diabetes screening program has been really well received, and we have a tremendous partnerships with both of our community partners at the Drop-In Center and at the Mustard Seed, and they've been really grateful for our team coming in and providing this added service and this added value to their clients who they normally struggle. And they, the care providers that work in these settings know all the things in the Diabetes Canada guidelines that people need to have their feet screened and their eyes screened, but they struggle because it's hard to get somebody somewhere and it's hard to get them to 5 different places. And so the fact that we're coming in and taking that burden off the community providers, and also the patients are really grateful too, right? They also, many of these people, the ones that are living with type 1 especially, have had type diabetes for years and decades. And so they know the routine and they know that they're 5 years out of date on their eye screening. And so they're actually really grateful that we come in and do this for them without them having to jump through all the hoops that are normally involved with that. So the reception has been really positive, and also from the referring providers, the people that we're referring to are, much lower no-show rates, right? When we are able to get somebody into their clinic in a week or 10 days, as opposed to giving them an appointment 4 or 6 months out, they've seen that people actually show up, and we have an infrastructure built around where we get people to where they need to be. We provide taxis and bus tickets and all those things. So the reception has been really positive. In terms of, for the people in this session, the sustainability is another issue, right? And this has been a great pilot program. We've had lots of success, but it's also been quite resource intensive. And so we've had lots and lots of learnings. And, it's something that we want to continue offering, but it probably is going to need to change in terms of how it addresses the needs of people to do it in a more cost-effective and resource-effective way. So yeah, always learning, and that's why we do these programs and do them and learn from them. In terms of the stigma project, we're still in a data collection phase there. So we're actually interviewing providers as well as clients to really understand this issue of stigma and discrimination. But people are really asking for the resource that we're planning to create. So that's our project over the next year, is to make this resource. But everyone we interview says, I need to know more about diabetes. This isn't something I've thought about, and it's something where I know that there's a deficiency in my knowledge. So there's an appetite for this, and so we're looking forward to being able to provide that to the community.
Wonderful. So it looks like you're going to get to do your education program, just maybe not in the way that you envisioned it originally. So
Yeah, exactly. Education for providers, not for clients. So yeah,
there you
very
go.
interesting.
So thank you so much for joining us today, Dr. Campbell. It has been, as always, wonderful talking to you about this project. And now we're going to get back to some of these pitches and our results. So I'm sure everyone's really excited for that. So thanks for joining us.
Thanks, Krista.